Bismillahirrahmanirrahim. My name is Dr. Rehman. I'm working as an assistant professor in the Department of Rheumatology in Faisalabad Medical University. First of all, I will like to thank the organizing committee of RheumaCon, who has given me an opportunity to talk on the topic of landscape of currently available biologics and JAK inhibitors in Pakistan, unveiling their potential, the limitations, and navigating the monitoring challenges. So as soon as the diagnosis of an inflammatory arthropathy is made, the recommendation is this: you need to start the disease-modifying drugs as soon as possible. So if we classify the disease-modifying drugs, they are broadly classified in three categories: the conventional disease modifiers, the biological DMARDs, also known as BDMARDs, and the targeted synthetic DMARDs, and labeled as TSDMARDs. So conventional DMARDs include methotrexate, sulfasalazine, hydroxychloroquine, and lefonamide, which are not included into the topic of this talk. And we will be talking on biological DMARDs and TSDMARDs. If we further classify biological DMARDs, biological drugs, these are the proteins that are genetically engineered. They are made inside the cell, and they are targeting a specific molecule, or they're targeting a specific cell which are involved in the cycle of inflammation. So once the cycle of inflammation is broken by these drugs, so there is no more inflammation, more inflammation, no tissue damage, and there is a halt to the progression of the disease. In this way, these act as disease modifiers. So number one class is the cytokine receptor therapies. Cytokines are the various proteins that are made inside the cell to initiate inflammation, to propagate inflammation, and to recruit other cells of inflammation to a specific site which is involved in the disease process. So cytokine receptor therapies include anti-TNF, interleukin-1 inhibitors, interleukin-5 inhibitors, interleukin-6 inhibitors, interleukin-17 inhibitors, interleukin-23 inhibitors. And the second class of biologics, they target the B cells. B cells, they play a very major role in the process of inflammation. And third class are the T cell targeted therapies. And T cells, they also play a major role in regulating the B cells and playing a part in the inflammatory process. And the complement targeted therapies. And the complements, they also play in the antibody mediated damage to the body, to the tissues. And the third class of disease modifiers are the targeted synthetic DMARDs, also known as JAK inhibitors or Janus kinase inhibitors. So first of all, we will be talking about the biological disease modifiers and their availability in Pakistan, and what are the prerequisites to start these drugs, and how to monitor during the treatment of these drugs, and what are the potentials of their use in Pakistan, and what are the limitations of their use in Pakistan. So let's start with the cytokine associated drugs. First of all, we will be discuss the anti-TNF drugs. So anti-TNF drugs, these are the biological agents that target the tumor necrosis factor alpha, a key cytokine involved in autoimmune and inflammatory diseases. So once the TNF is blocked, so the process that is initiated by TNF, the inflammatory process, is stopped at that point. Once the inflammation is stopped, the tissue damage is stopped, and the disease is modified in this way. So there are 5 anti-TNF blocking drugs that are approved for the treatment of various inflammatory disorders. Number 1 is etanercept, infliximab, adalimumab, certolizumab, and golimumab. Only etanercept is marketed by the manufacturer in Pakistan. Infliximab is somehow made available, but it's not registered in Pakistan. The biosimilars, they are recently made available. Same is the case with adalimumab. It is not marketed by the manufacturer in Pakistan. And certolizumab and golimumab, they are not available in Pakistan. So we'll be focusing on etanercept here, which is available here in Pakistan. So these are the anti-TNF drugs with their recommendations in various disorders. So they are approved and being used for the treatment of many inflammatory arthropathies, including rheumatoid arthritis, psoriatic arthritis, and inflammatory bowel disease related arthropathies, JIAs, and in some complications of the spondyloarthropathies like uveitis or in JIAs. So if we see the etanercept, so its use is a little bit limited as compared to the adalimumab, because it is not recommended for use in uveitis, and it is not recommended for use in inflammatory bowel disease and inflammatory bowel disease associated spondyloarthropathy. So it is recommended for use in rheumatoid arthritis, ankylosing spondylitis, psoriatic arthritis, and plaque psoriasis, and JIAs. So as etanercept is the only drug that is freely available, that is marketed by the manufacturer. So we'll talk about this in detail. It was approved by FDA in 1998 for the treatment of autoimmune disorders. So it has a long data available regarding its safety and complications and many other things. So its dose is a little bit different in pediatric age group as compared to the adult patients. Special warnings and precautions. So what are the precautions we need to take before prescribing this drug? And what are the monitoring challenges associated with this drug? So the topmost thing that should be seen before the starting of these drugs, the infections. Viral infections, the bacterial infections, the fungal infections, you need to look and screen for these infections before starting the drug. And the other infection that is very common in Pakistan, very much prevalent, is tuberculosis. So we need to look for tuberculosis before starting of this drug. We need to go for a test for latent tuberculosis even by doing some IGRA test. If it is positive, we need to treat the tuberculosis first, then we start on the drug. And the other two infections, which are very important, that are very much prevalent in Pakistan, is hepatitis B and hepatitis C infections. We need to get the serologies of hepatitis B and hepatitis C before starting the treatment, because it can reactivate hep B and it can worsen the hep C. And we need to look for allergy, any allergic histories of the patient, malignancies, any lymphoproliferative disorder, because as very data is available regarding the little bit increased chance of lymphoproliferative disorder with prolonged use of etanercept. Vaccinations is very important, as live vaccines should be avoided during the treatment with etanercept and other anti-TNF blockers. And you need to complete the vaccinations as a local protocol before starting of these drugs. So this is a list of side effects of etanercept. So the injection site reactions, headache, respiratory tract infections, GI symptoms, neurological symptoms, worsening of psoriasis. And this is the complication and adverse effect that need to be sought before treatment, during treatment, and after treatment of the serious infections. Blood disorders that need to be dealt with accordingly: hypertension, cutaneous vasculitis, liver and renal dysfunctions, and exacerbation of development of multiple sclerosis in a few cases. And the second class of biologic that belongs to the cytokine inhibitors is the IL-1 inhibitors, anakinra and canakinumab, and these are not available in Pakistan, so we won't discuss in detail, but these are recommended for the treatment of rheumatoid arthritis, for CAPS, like cryopyrin-associated periodic syndromes. So these are not available in Pakistan. And in future, inshallah, all these things will be made available in Pakistan as well. And the next is interleukin 5 inhibitors, epolizumab, and interleukin 5 receptor antagonist, bralizumab. And both of these drugs are not available in Pakistan. And these are indicated for the treatment in EGPA, also known as Church-Strauss syndrome, and in chronic rhinosinusitis, and in severe asthma as well. So next class is IL-6 inhibitors. So tocilizumab, sarilumab, and anti-interleukin 6 receptor antagonist is ciltuximab. Only tocilizumab is available in Pakistan, so we will discuss it in detail. So tocilizumab, it is indicated in a wide variety of diseases like rheumatoid arthritis, giant cell arthritis, systemic sclerosis associated ILD, cytokine release syndromes, COVID-19. It was widely used in COVID-19 in 2020 and 2021 with variable response, but it was recommended by FDA to be used in COVID-19. Systemic JIA and polyarticular JIA. So how does it works? Interleukin-6 is a pleiotropic pro-inflammatory cytokine. And it has many functions to do in inflammatory processes. It is involved in diverse physiological processes at T cell activations and induction of immunoglobulin secretions, initiation of hepatic acute phase synthesis. And this tocilizumab is a humanized IgG monoclonal antibody that binds to soluble and membrane-bound forms of interleukin-6 receptors. So once the receptor is blocked, so there is no signal transmission from the interleukin-6 for all these actions. So once these actions are stopped, there is no inflammation, no tissue damage, the disease is modified in this way. For prerequisites, if we see the prerequisites for all the biologics are almost the same. So there are three things that should always be borne in mind while prescribing these biologics. Number one is to screen for infections, look for latent tuberculosis, and do a serology for hepatitis B and hepatitis C. And live vaccines, they should be avoided during the treatment, and the vaccine protocols should be fulfilled before starting of these drugs. So monitoring is very much important to tackle the side effects at an early time, like CBC, differentials, hepatic enzymes, every 1 to 2 months, lipid panel, initially every 1 to 2 months, and once a stable dose is achieved, then after every 6 months. Warnings are the same, the serious infection, the reported infections that have been reported with the IL-6 inhibitor usage is the active tuberculosis, which may present with pulmonary and extrapulmonary disease. So test for latent tuberculosis should always be done before initiation of this drug. So other bacterial, viral, and infections due to opportunistic pathogens. So we need to closely monitor the symptoms and signs of infection before treatment, during treatment, and after stopping the treatment as well. So next class of biologics that target that cytokines is IL-17 inhibitors. So interleukin-17 inhibitors are secukinumab, ixekizumab, but only secukinumab is available in Pakistan. So we'll talk about this. Secukinumab is a human interleukin-17 antagonist indicated for the treatment of active psoriatic arthritis, adults with active ankylosing spondylitis, adults with active non-radiographic axial spondyloarthropathies, and active enthesitis-related arthritis, ERA, in pediatric age groups, moderate to severe plaque psoriasis, and adults with moderate to severe hidradenitis suppurativa. These are some dermatological indications for the usage of secukinumab. In psoriatic arthritis patients, adult patients, the dosage is 150 milligrams subcutaneous after every 4 weeks. If a patient continues to have active psoriatic arthritis, the dose may be increased to 300 milligrams after every 4 weeks. And this dosage can be given without a loading dose and with a loading dose. If one need to give a loading dose, it is 150 milligram weekly for 4 weeks, then shift to 150 milligram every 4 weeks. The same is the dose with ankylosing spondylitis. So warnings and precautions, also the same. The serious infections have occurred. Exercise caution when considering the use of secukinumab in patients with chronic infections or a history of frequent infections. So screen the patient for tuberculosis, look the patient for any history of inflammatory bowel disease, especially if you are treating a patient of spondyloarthropathy, because secukinumab can worsen the inflammatory bowel disease. And the same is the immunization protocol as was with the IL-6 and anti-TNF blockers. Monitoring is a periodic differential counts of CBC, hepatic enzymes monthly until a stable dose and every 1 to 2 months, lipid panel every 1 to 2 months until a stable dose and then every 3 to 6 months. So next class is anti-IL-23, and none of these drugs is available in Pakistan. So now the next class of drugs, that is a B cell target. These drugs, they are not targeting a specific cytokine, either they are targeting a typical target cell that is involved in the process of inflammation. So B cell targeted therapies include rituximab and palizumab and belimumab. Only rituximab is available for rheumatological uses in Pakistan. So rituximab is a monoclonal antibody that targets a CD20 antigen and it depletes B cells. And B cells, they play a very major role in the autoimmune processes, production of autoantibodies. When the B cells, they are depleted, so there are no more autoantibody production. And these autoantibodies, they are responsible for the tissue damage and inflammation in various organs. And it is also indicated in lymphoproliferative disorders. So how does it work? It binds to CD20 on B cells, and these B cells, they are either damaged through apoptosis, and either they engage the complement system, and it's a complement mediated damage to these B cells. In this way, the B cells, they are depleted. So once the B cells are depleted, so there are no more autoantibodies to propagate the process of inflammation. So approved indications in rheumatology for rituximab are rheumatoid arthritis and granulomatosis with polyangiitis and microscopic polyangiitis, classified together as ANCA-associated vasculitis. So we need to screen the patient before starting. So two major screening protocols for is to work up for hepatitis B infection and complete blood counts. HBV infection by measuring hepatitis B surface antigen and anti-HBC antibodies before starting the treatment with rituximab, because there are many cases have been reported in which there is reactivation of hepatitis B with the use of rituximab. So how to monitor it? CBC every 2 to 4 months to monitor for late onset neutropenias as well, IgG level prior to rituximab infusions in order to make sure that patient is not hypogammaglobulinemic. Recommended doses for rheumatoid arthritis, it is given as a 1000 milligram intravenous infusion separated by 2 weeks, and that may need to be repeated after 24 weeks. And recommended dose for GPA and NPA is 375 milligram per square meter IV infusion every week for 4 weeks. Warnings with rituximab. The fatal infusion-related reactions, they have been observed when 24 hours later than the infusion. So a patient who has been given rituximab should be observed for next 24 hours for the development of any infusion-related reactions. Severe mucocutaneous reactions, progressive multifocal leukoencephalopathy, other infections like bacterial, viral, and invasive infections, cardiovascular adverse reactions with some arrhythmias, renal toxicity, bowel obstruction and perforation. Immunizations should be avoided with live vaccines during the treatment with rituximab, and it is not safe to be used in pregnancy. So next class of drug is complement targeting therapies, eculizumab, and it's also not available in Pakistan. T-cell targeted therapies like abatacept, and this is not also available in Pakistan. JAK inhibitors, the next class of drugs that is recently approved for the treatment in various rheumatological disorders, and they are made widely available in Pakistan by different companies. And out of these three JAK inhibitors, tofacitinib, baricitinib, and upadacitinib, only tofacitinib is available in Pakistan, and it is being marketed by many companies for the use of tofacitinib is rheumatoid arthritis, psoriatic arthritis, polyarticular JIA, ulcerative colitis, and ankylosing spondylitis. What does it work? If you see here, the cytokines, they are attached to the cytokine receptors, and then the JAK enzyme is there inside the cell, and that is phosphorylating these STAT proteins. And these STAT proteins, then they go into the nucleus and cause the production of messenger RNA, which is then translated into the cytoplasm. And these cytokines and chemokines and other proteins, they are released outside the cell. So it blocks these drugs block this JAK inhibitor. When the JAK inhibitor, they block this JAK enzyme. When this JAK enzyme is blocked, so there is no phosphorylation, no activation of the STAT proteins. So inflammatory process is stopped at this point. So long-term safety issues are also with the related JAK inhibitors. These include the serious infections, malignancies, and lymphoproliferative disorders, increased risk of cardiovascular disease, hypertension, dyslipidemia, especially in old age patients, more than 65 years of age. And there are higher rates of pulmonary embolism and death using high doses of tofacitinib, that is more than 10 milligram in rheumatoid arthritis patient and patients with ulcerative colitis. So there is increased risk of DVT and pulmonary embolism, and this is a dose-related effect. If it is used in doses of more than 10 milligram per day, so chance of DVTs and pulmonary embolisms, they are increased. So other side effects that are observed with JAK inhibitors is the bone marrow suppression, hepatotoxicity, increased risk of various infections, other metabolic disorders, thrombosis, arterial and venous and pulmonary embolism, and malignancies like solid tumors and lymphomas are reported in tofacitinib group, but not placebo-related groups. So we need to look for all these effects during the treatment and after the treatment as well. And all these patients before starting of this drug should be screened for any active infection, for any latent tuberculosis, hepatitis serology. And if a patient comes out to be positive for latent tuberculosis, then this TB need to be treated first, and then the patient can be started on this drug. So what are the points where we need to stop this drug during treatment? If there is a hepatotoxicity, the liver enzymes, they are more than 3 times the upper limit of normal ranges. Bone marrow suppression, if a hemoglobin drops by 2 grams per deciliter or it falls below 8 grams per deciliter, there is lymphopenia, lymphocyte count falls below 500, or the absolute stop of tofacitinib until the count recovers and then restart at lower doses. So dose modification in renal impairment, no dose adjustment is required in mild cases. In moderate to severe cases, the dose is reduced to half. And in liver impairments, in mild cases, no dose adjustment. In moderate cases, we decrease the dose to half, and in severe cases, it is not recommended. In pregnancy and lactation, use of tofacitinib in females of reproductive age groups may impair fertility potential, so it should be used with caution. Its use in pregnancy and lactation is not recommended. And drug interactions, it can be used with the conventional synthetic disease modifiers, but it should never be combined with biological disease modifiers. All the pre-treatment evaluation need to look for any cardiovascular risk factors before starting, the blood counts and active infections, the T-spot TB for latent tuberculosis, hepatitis B and C serologies, liver function test, and renal function test. Monitoring baseline, we need to get the baseline test, then monthly for 3 months. And once the dose is stable and there are no side effects, and it can be taken to every 3 months. Maximum effect on lipid occurs by 6 to 8 weeks. Thus, lipid panel should be done by every 12 weeks. So now here comes, we will talk about as a general, the limitation of these drugs, as we have discussed, is the cost of these drugs. This is a study that was done in US. If we see the patients on different biological agents, the annual cost is roughly around 40 to 50,000 US dollars. That is very, very high. If we convert it into the Pak rupees, it will go around 10 to 12 million rupees per year. So, and another study that was done in Japan, and the first year of treatment, the second year of treatment, and third year of treatment with various biological agents, we see the cost is the same, around 40 to 50,000 US dollars per year. And if we see the situation in Pakistan, the average salary in Pakistan is around 81,000 Pak rupees, with the lowest of 24,000. And vast majority of the patients, they are earning in the range of 30 to 40,000 per month. And that is equivalent to 287 US dollars only. And that, if we compare it with the income in US, that is 7,900. This is a big discrepancy. And it's quite comparable with the India, but it is even lower than India. So average cost of treatment with biological agents in Pakistan is around 0.6 million per year. So a vast majority of the patients, they are not affording these biological drugs. So average cost of treatment with a JAK inhibitor is around 0.12 million per year. That is relatively cheaper. But even this drug is out of reach of a vast majority of the patients in Pakistan. So I think this is the real hindrance. So first hindrance is the infections like tuberculosis and hepatitis B and hepatitis C. And even the bigger hindrance is this economical situation in Pakistan, because there is no universal health insurance in Pakistan. Patient, they have to pay from their own pockets to buy these drugs for their treatment. So here we have some suggestions that the local guidelines regarding the treatment of autoimmune inflammatory arthropathies should be developed. Because in American College of Rheumatology and EULAR, they recommend the use of biological agents once there is a failure with a single conventional synthetic disease modifier. So a vast majority of the Pakistani population is not affording for this. So we need to develop guidelines in which we may look for the combination of disease modifiers. Further studies are required in which conventional synthetic disease modifiers may be combined to achieve the targets of remission in rheumatological disorders. And secondly, we can write to the authorities to increase the budget for the Sehat Sahulat program. And I talked to a local person of SSP, and he told me that the allocated budget for rheumatological disorders is only 60,000 rupees per year. So, which is quite, that is not sufficient to even buy a drug for 1 month even. So we need, and the same SSP program is giving around 1 million financial assistance to the patients of cancer and other neurological disorders. So we can write to the authorities that the budget of these rheumatological disorders may be increased so that population may get benefit of these revolutionary drugs, which really are important in the treatment of these diseases. So thank you very much. If you have any questions, I will be glad to answer these. Thank you very much.